Hello, everybody. Thank you so much for joining our live session today. We will get started here in a few minutes as everybody is coming in. Okay, welcome to Pre-Health Shadowing and our live session here today. My name is Aster Castro, and I am the Chief of Diversity at Pre-Health Shadowing, which is an international student-led, minority-led, and women-led nonprofit organization dedicated to helping prospective medical professionals gain access to educational resources, no matter what their demographic status, ability, or location in the world. So just a little PSA, we do have closed captioning for all of our live sessions to accommodate all students of all abilities. This setting is available at the bottom of your Zoom screen. And if you need assistance setting this up, please be sure to reach out to myself or one of our other team members here today, and we can help you get that up and running. If you have any ideas or on how we can be more accessible to students, we are always looking to do that. So make sure to email us at info@prehealthshadowing.com. So since this is an international program, we would love to know, where is everybody Zooming from today? I myself am just outside of DC. That's so cool. We've got everybody from not only the US, but it looks like we've got somebody from Romania as well, which that's cool. So if you guys want to stay in the loop and stay up to date on all of our live sessions, all of our initiatives, all of our opportunities, make sure to sign up for our weekly email list at prehealthshadowing.com. And then also we are active on Instagram and TikTok, so make sure to follow us on there. So because we are a pre-health centered program, we have a lot of opportunities for students like you guys. So just to introduce you to it, we have partnered with Kaplan to give you 10% off any Kaplan products, as well as free access to study guides for the MCAT, GRE, PCAT, NCLEX, and other standardized tests. So I encourage you to check that out. They are really helpful studying materials and can definitely get you on the right track for preparing for these exams. We have also partnered with Neolith, which is a mental health platform targeting young adults and college students in particular, to help us, maintain our sanity during these crazy pandemic times. I highly recommend you check it out. They have some great resources. It's also a way to just kind of educate yourself on different topics, get started in some community conversations, as well as build that background in not only physical health, but the mental side of things too. So be sure to use our code, which is PREHEALTH, when signing up to get to start with Neolith for free, or follow the link in the chat. We would also like to draw your attention to Mask for Mask. Mask for Mask is a woman-led business, and they donate 4 masks for every 4 masks sold during the COVID-19 pandemic to people in need. And this may be people in the homeless community, it may be professionals without proper PPE, it can be just anyone who is struggling to stay safe during this time. So not only is it for a great cause because you are donating masks, but if you use our discount code PHS15, you'll get 15% off, and 10% of the proceeds will go towards pre-health shadowing, which is amazing because we are a nonprofit that runs solely off of the donations and support of our community. If you are interested in playing a bigger role in pre-health shadowing, we would love to have you come on board our team or start helping out as a volunteer. You can volunteer asynchronously and do tasks at your own pace with no minimum requirement or commitment. Or you can come on as a team member and be up here with us and get to take part in some of the administrative leads and put together projects, do grant writing, lead different outreach initiatives, anything you can think of. So we would love to have you join us, and go ahead and check out the links in the chat to apply today. If you are a high schooler, don't worry, we've got your back. We have started a program which is called High School Training for Pre-Health Shadowing, and this allows high school students to not only network with each other, but also college students and different pre-health programs to learn how they can further their education and experience as they look to hopefully apply to these professional schools later on in their life. If you want to get involved with that, you can click the volunteer link in the chat and indicate that you're interested in HTP. Our lovely chief of HTP is Lorelai, and she's here today, and you guys can get connected and see how you can get more involved. If you're looking to get published, we've got you too. We are always looking to support our students in any way that we can. So we encourage, if you have articles, reflections, reviews, essays, even like a personal statement that you want to share and you want to get recognition for, we will most definitely publish it on our website, because, you know, the stories of all you guys, that's kind of why we started. It's why pre-health shadowing came to be, just a bunch of undergraduates coming together who saw a problem in the world and found the need to solve it. So let's get your input. Let's learn more about you. Be sure to use the link in the chat to submit your writing today. And it's a great opportunity to get this put on CVs, resumes, applications, etc. So this is really important because pre-health shadowing's main goal is to promote diversity and increase representation and eliminate disparities in the medical field. So as part of this, and as part of my job as Chief of Diversity, we are working to put on different events to encourage representation and equality in the field of medicine. And this includes our upcoming all-female women's health panel, which I'm going to talk about more in a second, as well as potentially a COVID-19 roundtable and an international student forum, which will be going on in the next couple months. So if you know somebody who's inspired you, they can be a professor, they can be a mentor, a professional, even a current student that you feel would be a great addition to our panels to speak on some of these topics, make sure to nominate them today. So yes, it is Women's History Month, and as we near the close of it, this weekend, which is tomorrow, Saturday, March 27th, and Sunday, March 28th, we will be hosting Women's History Month discussion boards with all female professionals to go more in depth about the different disparities and challenges that females face both as patients and providers in the field of medicine. We're going to be diving into some of the tougher conversations, but that's really important because none of the things that are worth talking about and worth fighting for and worth getting these topics out there, they're never easy to talk about. So make sure to join us. You can follow the link in the chat to make sure to RSVP. You can also find our Zoom link on our social media, our Zoom IDs on our social media, and be sure to join us tomorrow at 9 a.m. PST and on Sunday at 10 a.m. PST. So if you can, we humbly ask that you do donate to pre-health shadowing. Of course, we understand that is not always possible. We respect that because we are all at different points in our lives and our pre-health careers. So if you can, do donate, because our Zoom and our website are not free to keep up, but we want to keep this free for you guys. Alternatively, if you know somebody who you think who could donate to us, be sure to send this link to them. We would really appreciate it. Otherwise, just spread the word about our program, get it out to the students and the communities that need it most to help get them that educational support. So throughout the session today, I invite you to please type your questions in the chat. Our co-hosts will be asking them at the latter half of the session after the professional speaks. And of course, you're more than welcome to use the raise hand function at the Q&A portion as well. And you can unmute and ask your question out loud. Be sure to take good notes throughout the session today, because our post-shadowing assessment will be available for you after the session ends, and you'll earn 2 virtual shadowing hours on a certificate for attending. So stay tuned for that. We will be going over that at the end of the session. Last thing, if you can, turn your camera on, and it makes it feel a little bit more personal and allows us to connect a little bit more, especially since we are now in a time when social distancing is mandatory. So it'd be great to see more than just a couple black screens. We completely understand it's not an obligation, but we hope to see your faces. So thank you all so much for listening to my spiel, as always. And I would love to welcome Dr. Jennings to let me go ahead and present and start your presentation here today. Dr. Jennings, you can also unmute.
So there we are. So I'm an infectious disease doctor based in Manchester, the UK, and I've been working as a doctor for about 40 years. And what I'm going to do today is to take you through some of the interesting cases that I've seen and situations that I've met, and some of the ongoing work that we're doing towards the end of all of this. So I trained in London at the Guy's Hospital, and then I did some undergrad sort of residency training, or as we call it, the registrar type of work, and then a senior registrar work, which was like a fellowship. And then I came to the US to do a fellowship at Stanford, and then I went back as an attending physician, and in the last few years have been working a bit more in global health. So I'll tell you a bit about that. So I graduated when I was just 23 in London, and then my training then was in pediatrics, gastroenterology, hematology, oncology, in the early days of bone marrow transplantation, and then in infectious diseases. And I worked in London and Glasgow at that stage. And these are some of the patients that I saw. And this pair of patients are linked. And the question for you is, what is wrong with these two people? What do you think links them? And I'll give you the answers in a minute, but I just wanted you to have a little look. You can see there's a red stripe across this person's torso here, and this woman has got a facial palsy, so her face is drooping here. And here are two more patients with a different but similar problem. It looks they're both older men. You've got this rash, which is on one side of the front of the head here, around the eye, and also down here. And you've got this chap who's got it again on one side of the face, or the upper, the forehead. And normally rashes are on both sides, right? So this is a little bit unusual, but quite distinctive. And different manifestations of the same disease, a chest X-ray with abnormalities in the lower zone, bilateral here, and then this child with these very prominent spots with a big red area around them like this. So any suggestions, any of you? Have you twigged onto what all this might link together? And here was a teenager with a rash which is also related to the same disease, and in this case without much redness around these spots, these blisters, because these are all blisters on the skin, and it's very distinctive. So I don't know if that rings any bells for you. And then this is a much more typical example, and this is all linked with varicella zoster virus or chickenpox, if you prefer. And very, very typically, you have these small little ulcers inside the mouth, which are not painful, and then you have these spots and blisters on the skin as examples. And it usually is a childhood disease, but not always. And if you see somebody with some spots or some areas, it's very important to look inside the mouth, because it is so distinctive inside the mouth that you can make a diagnosis pretty rapidly. And this virus is highly infectious. It has an 80% attack rate if you're in the same room as somebody else. Very important that if patients are in hospital that they're isolated, because other people might not have been exposed to this virus, and it can be a very severe case. You may have had it yourself, and if in your family you've got brothers or sisters, the second child in the family usually has much more severe disease, and we don't usually treat the disease unless it's severe. And that is when patients who've got can't swallow very well, and some children have real difficulty swallowing, if you've got pneumonia, or if your immune system is damaged because you've got something wrong with your immune system. And so we generally have a much higher likelihood of treating second household in cases than the first case in a household. So going back to these cases, this is a shingles, a classical example of shingles with, it's actually on one side only, this rash. It's quite uncomfortable or even painful. And you get this what's called a neuralgia, which is a nerve pain associated with it. And you can be left with pain for weeks or months or even years afterwards, after an episode of shingles. Most people, it settles down fairly quickly within a month or so, but there are some people who have what's called post-hepatic neuralgia. And this woman's got a very distinctive syndrome, which is called Ramsay-Hunt syndrome with facial palsy. And she actually has shingles in the ear, and that has damaged or at least affected the nerve. And she's got this facial droop as a result of that. And this is one of the unusual complications of chickenpox. These patients have shingles on the nerves from the cranial nerves. So this is the trigeminal nerve, number 5. And you've got this, it's on one side. So in this case, it's the right side, and this one's on the left. And in this particular example, you've got a branch of this ophthalmic nerve, which also affects a little bit of the corner of the nose here. And that's called the nasolabial branch. And that same nerve that affects that also is the same nerve that affects or innervates the front of the eye. So a patient with nasolabial involvement will also have hepatic keratitis, which can be blind the eye. It can be a very severe infection. So these patients all need to be treated with antivirals in the eye as well, usually as systemically. And you also, in addition to getting skin infection, you also get a little bit of brain inflammation in a lot of these patients. And this patient had a mild encephalitis, which is a confusional state, sometimes with fever, related usually to a virus. And there's lots of viruses that cause encephalitis. And it usually settles down after 3 or 4 days or a week, as in this case, in this chap's case. You can get pneumonia from chickenpox, like this example, and that occurs in smokers and pregnant people and those who are immunocompromised, so patients having chemotherapy or transplant recipients. And it can be fatal. And I remember looking after one woman who was late stage pregnancy, about 35 weeks, with very severe chickenpox. And we tried to do an emergency cesarean section because she was dying of her infection. But unfortunately, we lost both the baby and the mother in that circumstance. And she was a pregnant smoker, and that was what happened to her, which was the problem. You can also get localized bacterial infection on top of the chickenpox infection. So this is a staphylococcal or Staph aureus infection on the skin on top of the varicella infection. And then this young girl, unfortunate girl, had Hodgkin's disease, was getting chemotherapy for that, and she got chickenpox. And this was before the time when we had antivirals for chickenpox. And she died about 3 weeks later of chickenpox everywhere, absolutely in all organs. And this rash got worse and worse and worse. And usually you have some redness around the rash, but she had none, and that's because she didn't have any inflammatory response related to the virus. So changing direction, this is another disease caused this time by a bacterial toxin, and I should say it's not really a toxin, it's a reaction to the bacterium. And you've got this curly-whirly, funny rash here, which is very distinctive. It's called erythema marginatum. And this child as well has got it. It's a little bit hard to see because of the magnification. And this same disease causes these little nodules under the skin. Any of you, any idea what that might be? Probably not seen it. You can put your answers in the chat there. And actually, this is rheumatic fever. So this is people who get a sore throat with streptococcus, and certain sorts of streptococcus, which causes typical tonsillitis and sore throat. have certain immunological reaction which results in rheumatic fever and produce a particular disease. And rheumatic fever can affect the heart, as you probably know. And one of the questions that we always ask people with heart disease is, have you had rheumatic fever? Because it can cause mitral stenosis in particular, but also other heart diseases. So narrowing of one of the valves in the heart. And so there are diagnostic criteria for rheumatic fever because the tests aren't very good. Growing the organism isn't very helpful. And this erythema marginatum is one of the major features of rheumatic fever. Subcutaneous nodule is a second one. And then there's another one where they get what's called a chorea, where you get sort of funny movements and you have a very odd movements related to the disease, which was in many years ago called St. Vitus's dance. And that's an eponym or strange name for this, what's called a chorea related to the disease. So it affects the brain a bit and how you move. And then you've got diseases affecting the features in the heart as well during acute disease. So rheumatic fever comes in waves. It's very rare now in the US, but you get outbreaks in various parts of the world, usually affecting children. And it has had a major impact on cardiac disease across the world. Okay, so now I'm going to ask you what the diagnosis of this young woman is. So she's got conjunctivitis where she's got very red eyes, and if you pull back her eyelid, you can see bright red eyes there. She's got a rash on her body, and she's got a bright red tongue here, and sort of red lips as well. She's got a low blood pressure, she's got fever, and she's got array-CPK, which is a muscle enzyme which you can measure in the blood, and she's got a low platelet count as well, which is quite characteristic. And it's quite uncommon, but it definitely occurs. It's much more common in young women than young men, and it's much rarer in older people as well. It has been reported. And the answer is it's a toxic shock syndrome. So this is a toxin-mediated disease, could produce from a bacterium called Staph aureus, and only a small number of strains of Staphylococcus produce this toxin, which is called toxin syndrome toxin 1. And it's what's called a superantigen disease. So it activates lots of the immune system. It binds to receptors and just fires off loads of inflammatory markers with lots of cytokines around the body. And it's linked to menstrual cycles in women, but using a tampon. So women who use pads don't get this disease, but if you use a tampon, there's a risk, and it's particularly common in late teenagers or early 20s. Or you can get a wound infection with the same organism, and you can get this toxin produced as part of a post-operative infection. And so you have this very characteristic presentation of high fever, faintness and dizziness. And when you measure the blood pressure when a person's standing, it drops a lot, and that's not what should not happen. So that's called postural hypotension. You have a red mouth and conjunctivitis. You have this faint body rash, although in the woman I showed you, it's a bit more obvious. And then your various organs like the liver and the kidneys and the blood count and so on can go into overdrive and failure. And when it first came round, there was really quite a lot of problems with it. And in this first episode, which was really described and put it on the map, 1979, over 38 women died as a result of it. And this was related to a super absorbent tampon. And that tampon, what was in it to make it super absorbent, it activated and got the Staph aureus to produce more toxin. So it was sort of generating more toxin from the bug. And that meant that many more women got this problem. And eventually, Procter & Gamble withdrew this tampon from the market because of this episode. And this was picked up with, actually in Denver, the first cases came through, and the CDC was very active in addressing this. when you recover, because about 90% of people recover from this illness, about 10% die of it. But during the severe episode, you can get what's called peripheral symmetrical gangrene, where you get constriction of the blood vessels in the ends of the toes and the fingers, and they go black like this. And you can get that disease with other things. There are other infections and toxins that can generate that, but toxic shock syndrome is one of those. And then you have peeling of the skin, and it's very characteristic, the peeling. It's masses. You can see, I mean, sure you've never seen feet like that. And this is a very typical feature of toxic shock and other types of superantigen diseases. Okay, so that's one unusual diagnosis, but interesting because it's a toxin and an immunological driven disease. What about this infection? So this is two different people with a mouth with little ulcers in it and a rash on the face that you can see around here. And this is another man with a rash all over his trunk here. And both these patients had a bit of fever, touch of diarrhea, sore throat. They were very tired, bit of headache. This was the rash, which was described as rubella-like. It's actually, or German measles-like. It's actually not quite the same, but it is similar. They have also red eyes. They have glands that are up in the neck or the groin. Their liver and spleen can be enlarged as well. You can have ulcers in the mouth or genitals, or even in the esophagus and the gullet. And then the white count is a bit low and the platelets are a bit low. Any idea?
It looks like in the chat we have meningitis or potentially HIV.
Okay, good. It's primary HIV infection. So this is the illness that you get the first time you get HIV. All right, so it's not AIDS. It's not that latent phase where you might be transmitting the virus. This is primary HIV infection. So you get a blood transfusion from somebody who's infected, or you have sex with somebody who's infected, and this occurs later, within 2 weeks usually, maybe 3 weeks. About somewhere around 40% of people who catch HIV have a primary infection that you can, as a clinical disease. The rest get asymptomatic infection. You wouldn't even know they'd had it. They just don't know. And these are quite severe cases, these ones. You can also have quite mild cases. You just have a bit of sore throat and a bit of headache and a bit of tiredness for a few days, and then it goes away. And that can also be primary HIV infection. And the people who get an overt bad illness related to primary HIV progress to AIDS much earlier. So the normal time from acquiring HIV to getting AIDS and presenting with AIDS is about 7 years. So you've got this long time frame where you're infectious and the immune system is gradually being eroded and damaged, and then you get, the infections related to AIDS. These people with primary HIV infection progress to AIDS in 3 years, not 7 years. So this is a very important diagnosis if you can make it. And also these people are super infectious at this time. I mean, they have so much virus. So if you happen to have a needle stick taking blood from this patient, woo, that's a lot of virus inoculated. I mean, if they're this ill, they're not going to have sex. But if you had slightly milder illness and, a week later or 2 weeks later, they're going to have masses of virus going around as well. And you can detect that. You can do a viral load test, a very high viral load. And actually, their immune system is quite delicate at this stage with this leukopenia and thrombocytopenia. And you can even get opportunistic infections or sort of complicating infections on top because their immune system is so damaged with primary HIV. We saw a patient, so this was a long time ago, this was published in 1987, and this patient I think came through in 1985. So HIV was really first recognized as a problem in about 1980. The first few patients, few gay men that were Aprilia picked up was in late 1979, and then there was more and more patients reported in 1980. The virus was isolated in 1983, and the first antibody tests to detect the virus was in 1985. So this was really at the beginning period of that learning about HIV and being able to test. And we saw this young man, 29 years old, 2.5 weeks of severe sore throat, painful mouth and fever, night sweats, dry cough, very tired and bad headache. His previous sexual contact had been 5 weeks earlier. So this was quite a delayed primary HIV infection. And on day 5 of his illness, because we didn't really know what was wrong with him at this stage, his leg felt stiff and his gait, he was walking, was all unsteady. And when we examined his reflexes and his muscles and so on, we found that his legs were sort of very increased in tone, so they were sort of a bit more rigid than normal. He had brisk reflexes, and normally when you test the foot, the big toe goes down when you test it, but in this case it went up, and that's what you get with a problem in the brain or in the spinal cord. And he had shaking legs, and also he found it difficult to pee, and that's very typical of a spinal cord problem. And this went on for 2 weeks. And so we made a diagnosis, and Peter Rudge was our neurologist at that stage, of acute myelopathy. So this was the virus damaging his spinal cord. And with primary HIV infection, you can get these general features of fever and weight loss and feeling tired, headache, and this neuropathy, which is one of the things he's got, this sore throat, lymph nodes, rash, feeling a bit sick, a bit of diarrhea, liver and spleen, muscles, and so on. But you can also get this neurological features as well. And that's one of the unusual features. You can also get a sort of meningitis, what's called like a viral meningitis with primary HIV. So during that same time frame, when I was working, this was in North London at Norfolk Park Hospital, we had this woman in who had difficulty. She passed these funny balls in the urine. And when we investigated it, you can see this, this side of this kidney is very, very different from this side. So the side I'm illustrating is normal or nearly normal, and the dye has gone down and you can't see it much. This side, there's a lot of obstruction and these funny black areas. So there's something in the pelvis of the kidney, which is where these are. And this woman was a diabetic Indian woman, and she had undergone what's called a pyelolithotomy, which where they've gone in and taken out some stones from her, the collecting duct from the kidney, but she had got infected because she then passed these soft balls, which we then analyzed in the lab, and actually they were full of aspergillus. So she had a post-operative infection from aspergillus from the air in the operating room. And this is a patient I've just been asked about. This is a transplant patient up in Glasgow who had an aspergillus terreus infection of his sternum after his heart transplant. And so he's on antifungals, and this is the brand new shiny antifungal called isavuconazole, which you take every day by mouth. It's sort of easy to give. And he, for the last 6 months, he's been passing these little things in his urine, and these are the same in concept as this woman, the previous woman. They're a bit more irregular than this one, but it's essentially the same thing, and it's called a fungal bezoar, which is a very old term. And in his case, it's caused by a fungus called Aspergillus terreus, which is a brown fungus. And the problem with that is that fungus is usually sensitive to isavuconazole. So you'd expect the isavuconazole to work. But like all the antifungals that are active against aspergillus, it doesn't get into the urine at all. It goes around the body, it gets into the lungs, it goes into the brain, but it doesn't get in the urine. So what's happened in this man is after his transplant, when he got this infection in his sternum or breastbone, he must have had a little bit of dissemination around the body with the aspergillus, and it ended up in the kidney. So they got his chest better, and that's sort of fixed. But because the antifungals don't get into the urine, it's been able to grow there. And he's got like a little growth in the pelvis of the kidney, just like this other woman on this side here. And actually, it's a very difficult treatment problem because there's no drugs that get into the urine. And so what they normally do is they stick a tube up. So you feed a tube all the way up the ureter. So through the urethra, into the bladder, up here, and then you have a catheter, and you put antifungal therapy there. You directly inject it into that area. And the drug we usually use for that is amphotericin, which has been around a long time and safe. But Aspergillus terreus is resistant to amphotericin. It won't work at all. So actually, this is a really, really difficult problem for which we don't have a good solution. And I've suggested that they try injecting a different antifungal, a bit like isavuconazole, but actually and do that and do it directly. But the alternative is to take his kidney out. And that's actually what happened in this woman, is she had her kidney taken out because she had a normal kidney on the other side, and this wasn't easily curable with this. So I just wanted to illustrate, this is a really rare problem, but it illustrates something about the pharmacokinetics and the drugs and resistance issues all together. So after all of that time, I then went over to Stanford and worked at the Valley Medical Center, which is in San Jose, with David Stevens, who's an expert on fungal disease, and John Hamilton, who ran the microbiology lab. And I was there for 3 years, and we did lots of interesting things. Here's Dr. Stevens. He looks a bit like Father Christmas, and he's even whiter now, so he really does look like Father Christmas now. And he's a very, very smart, very conscientious, detail-focused person. And he trained in virology and then went into mycology or fungal diseases. And because I'd done some work on and seen some of these patients, that's why I ended up working with him, which was great. And while we were there, we had the local Loma Prieta earthquake. This is probably before you were born, I guess, for many of you. And this was a big earthquake. I was doing some mouse experiments as part of my work. And it was about 5 o'clock in the afternoon, and all the cages and the lab started shaking. And I thought, oh, shall I leave or shall I not leave? And so on. And it went on for about 3 minutes. It was really scary. Anyway, it did stop. And I thought, well, I better finish my experiment. So I finished injecting all my mice. And then took about 15 minutes, went down with some leaking things in the lab, picked them up and drove home. And at 5 o'clock in the afternoon in San Jose, there were cars everywhere normally. But when I left, there was not a single car in sight. The place was completely deserted. And they had some, one freeway fell on another freeway and about 30 people died. But fortunately, because there was a baseball match on, there weren't nearly as many people on the freeway as normal. And many of the houses in Los Gatos, which were a Victorian era, had to be demolished because it was just so bad. Anyway, that was the excitement of working in the Bay Area. And so, not great, but that's what happened. So one of the patients we saw there, well, these are 2 different patients, were these advanced HIV disease with funny lesions. So this one's got a big thing which looks like a tumor sitting in the bottom of the lung here. And here it's harder to see, but there's bilateral shadows on this patient here and a circular lesion here as well, and maybe a little bit of extra shadowing here. And so this lung is not right as well. And in both of these patients, we didn't know what the diagnosis was, but actually we grew aspergillus from them, and actually they had invasive pulmonary aspergillosis in HIV. which had not really been described before. People assumed you'd have lots of Aspergillus because it was an immunocompromising infection, but actually it wasn't a big problem in HIV at that stage. But this, the patient who had this lesion grew 2 strains of Aspergillus, which we labeled AF90 and 91. And this patient was put on compassionate use itraconazole, and so was this one. This chap improved and survived, and this one didn't, and he died. And we published these patients. So this was my first paper in the New England Journal of Medicine. Yes, that's a real big hit, right? To do that. And it was a case series of patients with aspergillosis in AIDS, which hadn't really been described. So that was in 1991. And so again, not too soon, late after the thing. And there was a lot of thing, and Dr. Stevens always writes on it. And here is another example, which was in that series of a patient who had some bilateral faint shadows in both lungs here, and then it got much worse. You can see a sort of a big mass-like lesion here. You can see the EKG leads showing this patient was in hospital and not very well at all. And this patient died 3 days later and had aspergillus in the stomach, and the stomach had bled. And so, this was a disseminated aspergillus through the lungs. And so this was new, and the drug itraconazole, we were still trialing at that stage. It was oral, the first oral treatment for aspergillus. And some of these patients went into this a national study of looking at the value of itraconazole therapy for invasive aspergillosis. And this study led to the registration of itraconazole, which is still used today all over the world. And only about 3 years ago, we had it classed as the central medicine by the WHO. So I then returned from the US to the UK in Manchester. I was 33 at that stage, and that was when I became an attending. This was an academic, part academic, so I was doing about 50% clinical, 50% research work. And one of the things I brought back with me were these strains. I had another one as well, but AF91 from that patient who failed itraconazole. And we did a lot of work to show that it was actually resistant to itraconazole. And this hadn't really been done before. We didn't really know. And the resistance was there before itraconazole was approved and available on the market. So even before the drug had even arrived on the scene as an new antimicrobial, there was resistance in the environment. And we did some mouse work in these experiments, and even a very large dose of itraconazole wasn't good enough to save these mice. It really was a lethal infection. And we later found that it was a strain with a mutation in the target for itraconazole called M220. And this work led to the defining resistance for a start, defining how to do the testing globally. And now we are seeing resistance across the world to itraconazole related to the use of azoles in crops. So we spray all our crops with azole fungicides, and that generates resistant aspergillus in the soil, which we then breathe in. So this work, I didn't expect that to happen with all this work, but that's what did happen over time. And another thing I got to do when I was back in the UK was to study the next antifungal for aspergillus called voriconazole. And we started studying that in 1993. And this was the study. It was called UK 109496 at that stage. And this was in chronic aspergillosis. And it was a little old fever hospital called Monsell Hospital where I was working. And this was one of the patients we treated. This is Anne. And she was pretty poorly. She had cranial nerve palsies. So this is a normal, this is her normal eye. She's looking to her left, and this eye is not moving across properly. So she's got a defect in her 6th cranial nerve. And here she's been told to stick out her tongue, and it doesn't stick out straight. It sticks out to one side. And that's a cranial nerve 11. So she's got 2 cranial nerve defects. She's completely walking and talking normally, but she's got these defects. And the reason is because she's got aspergillus in the bones of the skull, a skull base infection here, from aspergillus that came from the sinuses, which is the back of the nose here. And it may not be obvious to you because you haven't seen many of these, but this is another view from the CT scan. And this is like a moth-eaten bone. It's got these patchy black areas. It should all be white, the whole thing. So this is aspergillus sitting in the base of her skull. And she's not immunocompromised. She was otherwise a normal woman in her 40s or so. And she just got this from an infection in the sinuses. And she'd already been treated with itraconazole and failed. She'd had other treatments, they'd all failed, and she'd been a problem. And she was actually the first patient with aspergillosis that was treated with voriconazole in the world. It was really, really an extraordinary thing. And she did so well. She had this, what was called sphenoid sinusitis, base of skull aspergillosis, so really unusual combination. Here she is. And she developed one of the side effects of voriconazole, which is photosensitivity. So she went bright red with it. And we didn't know that that was going to happen with this illness, with the treatment, but that's what happened. She was treated actually for about 14 months. And she was cured, absolutely cured with a new drug. So this was fantastic. We were so delighted. She was delighted, of course, but we were delighted as well. Here's a new drug, got her better, magic. She did have this photosensitivity, and she also got another funny skin reaction to the drug called discoid lupus erythematosus, which is skin, and that all resolved once we stopped the drug. And here's an example of Roger, who I looked after for about 25 years on antifungals the whole time. And here he is in 1994, also on voriconazole with his photosensitivity. And he came off that eventually because he was just, his face was just, felt like it was being stretched all the time. It was really uncomfortable for him. And here he is many years later, smiling. He's actually had developed multiple sclerosis as well. So he was in a wheelchair, but he was still going strong, still with his aspergillus, still on antifungal therapy. So 25 years later. So I don't know if you've heard of patients taking an antimicrobial for 25 years. They do with HIV, of course, but actually it's fairly unusual. So, and this is his story about why he was on it. So he was actually in Vancouver. He was a smoker, but he was from Manchester area. And he presented with a cough and this new infiltrate up here, which is quite hard to see here. And there it is on the scan. And this sort of nodule with these sticky out things, what are called spiculation, is quite suggestive of lung cancer. And he was a smoker. So the standard approach to that, take it out, take it out. It wasn't very large. It was easy. So he had a lobectomy, and that got rid of it completely. And they found aspergillus in it. And the pathology actually showed a granuloma, which you actually normally see with TB. So they treated him for TB because they thought it was TB, but actually I don't think it was. It was all aspergillus. And he was then cured because they'd taken a bit of his lung out, and it was fine. But in 1992, so this is all 91, late 91, in September 92, he had a new lesion here. Now, this is not the same bit of lung. This is the lung that was in his lower lobe that's now moved up to his upper lobe, right? Because he had the upper lobe taken out surgically. So this is a whole new cavity which has occurred after surgery. And that's what it looked like on CT scan here. Well, that's not supposed to happen. You're not supposed to have that. And he was one of the first patients I saw with this normal immune system, but recurrent aspergillus in the lung. So why did you get that? And you have in this a strong antibody response to aspergillus. And what is the diagnosis? And this is what happened to him. And we coined the term chronic cavitary pulmonary aspergillosis, which is like other fungal infections like histoplasmosis and coccidioidomycosis. And this is what it did over time. It changed the cavities. You can see these appearances are all a bit different. And it was very slowly changing. And so it's very chronic, long-term problem. And this is why he ended up on antifungals for 25 years. Now, once we did that study, but we also did a study of invasive aspergillosis, which is in patients who do have damaged immune systems, leukemia, transplant, and so on. And this large randomized study generated a survival benefit for patients with invasive aspergillosis. So voriconazole was then licensed, and it's still used today. Again, there are generics, and we've also persuaded the WHO to take it on as an essential medicine. But this was published in 2002, and we've been using the drug ever since. And you see, our study started in 1993, so that gives you some sense of the time frame that it takes to do this. And here's another patient I saw. This was a woman who was completely well, but she needed a hysterectomy. She's about 50-something, about 50, I think. And she had a chest X-ray before her surgery, and they found this funny lesion here. And they said, oh, what's all that? So they then diagnosed sarcoidosis, which is a disease of unknown cause, usually affecting the lungs. And because sarcoidosis is treated with steroids, they gave her some steroids. And she then has filled in this whole area like this. And you can perhaps see a sort of round lesion there, but that's probably the rib lesion. And then she then gets this new cavity formation, pleural thickening, and she's got a small fungal ball inside here as well. And it gets even worse. And now you can see a much larger fungal ball here inside this cavity. So the steroids have allowed the fungus to go wild. So they've treated one disease and ended up with another one, aspergillosis. And so this is one of the patients we learned, you really have to control the fungus. You can't just treat the underlying disease. You have to manage and treat the fungus. So she ended up on antifungals for quite some time. And once she came off steroids, actually, she stabilized and it wasn't so bad. So chronic pulmonary aspergillosis occurs in those with underlying lung disease. It's a pretty uncommon disease. We've just about worked out what the genetic basis of it is, and there are multiple gene defects. So we've had to go into genetics, which I didn't really know anything about before. Because it's got a genetic basis, it's probably incurable, but patients can have long periods of remission on antifungal therapy or sometimes off antifungal therapy. So Roger, for example, relapsed immediately after coming off antifungals, but on antifungals, he's been maintained and is pretty good. But it can be very quiet illness. And I wanted to show you lung function tests, which we do in patients with lung disease. And this woman relapsed after stopping treatment, but she had no symptoms apart from a bit of breathlessness. So 3 years before, she had what's called a flow volume loop, which looks like this. So the green is the normal, and she was the blue, and that's not too bad. It's a little bit of airways obstruction, which you get with asthma or smoking lung disease. But you can see the difference in there and there, where the green is the same, but she's lost a lot with the blue here, and that's over a 3-year time frame. And you can see the numbers 1.9 to 1.4 here, 3.1 to 2.5. So this is a slow, almost silent progression of this disease. With the only feature is breathlessness, because she's got scarring in the lungs affected from her aspergillosis. And this is one of the reasons it's a difficult disease, because, you know, how would you know this if you're not coughing up blood and everything? But it's a bad disease to get. So this study from Japan shows that if you have patients who grow aspergillus in the lungs, this is not a young age group, typical age 72 in this group, you have about a 20% mortality over 5 years. But if you have aspergillosis, you have a 20% mortality in the first few months, and then overall about an 80% mortality. So this is not a great disease to have. And obviously in this woman who's about 50, 54, I think she was, you've got lost a lot of lung in the space of 3 years. So, you know, a normal 50-year-old in the UK would be expecting to live until they're 80 something. This is a much faster progression than you'd expect or want. So this took us into understanding where these patients might be, and there was some older work suggesting that it was a complication of TB. So if you had TB and you had a cavity in the lung after TB, then you could get aspergillus. And we did a modeling exercise, and we thought there were nearly 1.2 million people around the world with this infection, and about 375,000 new cases every year. So that's a lot of people. And so we then decided that we needed to check this because this was British data. And so we set up a study in the north of Gulu, or north of Uganda, right? This is Kampala up here. And we were right up here in Gulu, which is where, I don't know if you ever studied the history of this area, but the Lord's Resistance Army came in and invaded this area and were really horrible to the local populace. And Ian Page was a young research fellow working with me. He and I went out there to scope the project and sort it out. And then he went back and spent many months living there doing a project. This was the local hospital, Gulu Referral Hospital. This is this fantastic colored soil, which they have in many parts of Africa, this sort of ready, sandy soil. Patients and relatives sitting outside. Often patients don't get fed in hospitals in Uganda, so the families come and camp and feed their relatives, and they're sort of look like old single-story huts and different wards and so on. This was the pharmacy or dispensary, and here's the nurse organizing everybody, and they're all waiting for their medicines. And here are the prisoners being marched in to the HIV clinic to get their HIV medicine every day, because a lot of it, obviously in Uganda, there's a great deal of HIV, and they need to treat the prisoners as well as everybody else. And this is the infectious disease clinic there. This was the patients with HIV were waiting. They were having their CD4 cell counts done, and they were talking to the doctor and then waiting for their medicines. And actually Gulu was distinctive because one of the major outbreaks of Ebola occurred in Gulu, and they had an isolation unit there, which was just at the back of this area, where they put these very first patients in the whole of Uganda recognized to have Ebola about 20 years before this. This was opened by somebody from PEPFAR, and they were able to do chest x-rays, but they didn't have any working boxes to look at the chest x-ray. So this is the x-ray being looked at against the clouds, and you can see the clouds here. And I don't know if it's sort of very easy to interpret a chest x-ray with you've got clouds behind it, but that's what they had to do. So we worked here and generated really quite a lot of data. Ian recruited 400 patients, half of whom had HIV and half of whom didn't. And then he did 2 evaluations about 2 years apart. So we lost about 115 patients between the first and second survey, because some of them had died, we think, some moved away, some changed their mobile phones and we couldn't find them. And we found chronic pulmonary aspergillosis in around 5% of the patients overall. If you include these ones that weren't fully proven, it's about 6%, but it's that sort of number. There was a rough equal distribution between HIV positive and HIV negative, and nobody had really studied HIV positives before. And we then looked and worked between the 2 surveys, how many had developed aspergillosis, and it was actually an annual rate of 6.5% if you had X-ray cavitation. And if you didn't, it was 0.2%. So having a hole in your lung where aspergillus can land and set up shop is a big factor in driving aspergillosis in these patients. And So this study, the modeling, this study, and this work led us to set up a foundation called Gafi, or the Global Action Fund for Fungal Infections, which we set up in 2013. And we're still very active. And today, for example, I had a call with 4 people at WHO, the head of their TB program, the head of their communicable disease program, to try and put fungal disease a bit more on the map. There's loads of gaps around the world. We've done a lot of additional modeling on top of that modeling I showed you from CPA. We think on any one day, there's about 30 million people who may die of a fungal infection, who have got leukemia, lung cancer, COPD, severe asthma, HIV/AIDS, TB, critical care, COVID patients are getting aspergillosis, influenza patients, and so on. So a large number of different patient groups, those on dialysis, premature babies. There's a whole load of patients who are at risk. In fact, you can see a prem baby here and another one here who get aspergillus. This is a fungal eye infection where the fungus gets into the eye, and we think there's about 1 million eyes affected a year. And this is a man from Guatemala with a HIV and disseminated histoplasmosis, which is in the soil from bat caves and bird poop, which is very common in Central America. And he's got that. It's a very severe infection and many patients die. Anyway, so of the 30 million at risk on a given day, each year we think there's about 2 million deaths. And that puts fungal disease around the 5th cause of death, usually with something else. So usually with leukemia or HIV or in critical care or something else. But it's a lot of people who die. And nearly half of the AIDS deaths are probably HIV, fungal, in fact. And if you and I were Jeff Bezos or Warren Buffett, and we waved a magic wand and everybody could get diagnosis and treatment tomorrow, we think that we could save about 1.3 million of those lives. Not all of them, because the diagnostics and drugs are not perfect, but also the patients, some of the patients are really end stage with untreatable leukemia or very severe comorbid problems in ICU. And what Gafi is trying to do is to work towards a world free from death in particular, but also suffering from fungal diseases. We're focusing more in low and middle income countries rather than just the high income countries. There are many needs in North America and in Europe, actually, but there are even more needs in low and middle income countries. And one of the things we've been doing is listing drugs, as I mentioned, on the WHO essential medicines list. And we've also listed a lot of drugs on the WHO's essential diagnostics list as well. And so that has been successful. And that means that countries around the world should be taking up these infections, these diagnostics and treatments. And I thought I would finish by just showing you some other fungal infections from different parts of the world. So this is a HIV patient with disseminated Penicillium mahnefii, which is related to where bamboo rats live in Southeast Asia. It's not from the bamboo rat directly, it's just that's where the fungus lives alongside in the soil and patients breathe it in. Coccidioidomycosis is in dry soil in Western US, so that in the Central Valley, the San Joaquin Valley in California, New Mexico, Arizona, Texas, Mexico, and then other spotty parts of Central America. Aspergillus is a global infection, and this was a leukemic who had a brain abscess, and this is obviously an autopsy, and this is the area of Aspergillus here, and that's a immunocompromised patient. I think this patient had leukemia. This patient from Papua New Guinea has got a skin infection caused by fungi that are in plants or on the surface of plants, and this chromoblastomycosis is now a neglected tropical disease by the WHO because Gafi applied for that process. Oral candida is common anyway, particularly in HIV, late stage HIV, but also in patients having radiotherapy or patients using steroid inhalers in asthma. So you can have oral candida in that context. And this was a patient with, this is from France. And actually this is fluconazole resistant. So this is an AMR problem. This is a prem baby that we've talked about from the US with candidiasis. This is Asperger's sinusitis. So like that woman who got the infection in the skull base, this is what she could get, or she didn't actually. And then fungal hair infections are very common in African school children, about 135 million of them. So it's a very common problem and not very pleasant for the kids. So with that, I'm going to stop, and I wanted to show you a video, but I just need to find it to show it. But I'm really happy to take some questions if you've got any questions. Let me see if I can pull up my video, which I should have loaded before, but I failed to, I'm afraid. So I've just got to find the relevant file, which will take me just 2 seconds. And oops, sorry, that's the wrong one. Click, click, click. What if, it's a big file, so it's difficult to transmit. That's why. It's there we are. So if I unshare that screen and then try and share this screen. Now I hope you'll be able to hear it. That's the thing.
I'd love to kill you with a kiss. I'd like to strike you down with this. I'd like to tie you up in knots until your heart stops. I'd love to kill you with a glance. I'd like to put you in a trance. I'd like to drug you with my scent and use you in the moon. I'd love to kill you as you eat. Pleasure would taste so sweet. I'd like to open up your skin and want to live within. I'd love to kill you by a stream where no one can hear my baby scream. Then I'd run away and be free, the sweetest victory. I love to watch you in your sleep, 'cause you don't have power over me. And when you're awake, I'm undone under your spell. In hell.
That's it.
Thank you so much. We can definitely get into some of the questions that were in the chat if you're ready to answer some of those.
Yes, so that's fine. So now I can see them. Where should we start? HIV. Oh, you got it right. Some of these, well done. Right. So I think, Asta, you've asked a question: what factors contribute to the time which it takes for an infectious disease to progress in someone's body? Are certain demographics that are more susceptible? Yes, so it's pretty complicated, that. So you've got infections in normal people. You've got an incubation period, which varies a lot. So the incubation period for influenza is a day or day and a half. For COVID is 2 to 5 days, typically. For chickenpox, it's 10 to 21 days. Measles is about 10 days. So you've got those types of incubation periods. You've then got also latent infections, which can be years later. So TB is a good example of that. Histoplasmosis is another example, where you can have the infection and it just doesn't appear for years and years later. Another example is an amoebic liver abscess, which you catch from dirty water. So there's a huge variation in how the timeframes that patients get these infections. If you're immunocompromised, it's usually faster and worse, as a general statement, but it can be bad in normal people, as you know from COVID. Now, then there's a question here. Can you get toxic shock syndrome from a wound that hasn't undergone surgery? Yes, you can. Yes, you can. It's uncommon, but you can get it. And that's one of the ways that these present. Are complicated cases of zoster or chickenpox common? Well, shingles is pretty common, so, or herpes zoster. Complications otherwise not that common. I mean, there's a bit less smoking than there used to be. It's not that rare, not that common for women to catch COVID, chickenpox in pregnancy, so that's a little less common. But it's not a rare problem, actually. It does occur.
I would also like to open the floor if any of our participants here today want to unmute or use the raise hand function. You're welcome to ask your questions directly.
Yeah, please do. You're most welcome. Sounds like a lot of these cases would occur in the ER or urgent care setting. So I hope that isn't a stupid question, but are there specific clinics that deal with infectious disease or severe cases, which would be a normal disease with a normal progression? Yeah. So TB patients tend to go to special clinics. HIV, they go to special clinics. Travel clinics have two functions: vaccination before you travel, to check what you've got, like if you're going to somewhere you can get bitten by a dog, you get rabies vaccine or Japanese encephalitis vaccine or something. And then after you've been traveling, you come back losing weight or diarrhea or a funny rash, and there's a travel clinic related to that. So those are very well established. There are, in big transplant centers, there are evaluations before the transplant for infectious diseases, and if you get an infection afterwards, then you have a joint clinic afterwards to monitor the transplant and the infectious disease. There are chronic disease clinics for fungal disease. So Lyme disease is pretty common, for example, and there are Lyme disease clinics. Various fungal infections like coccidioidomycosis, aspergillosis, and these skin things like mycetoma and chromoblastomycosis, they tend to come into clinics as well. And then you have general infectious disease clinics for patients with who've been in hospital and then they're being checked after they come out of hospital. And I mustn't forget, of course, hepatitis. There's a lot of patients in hepatitis clinics as well, which is long-term. So yes, a lot of infectious disease is on the wards and it's very acute and patients come and they're very sick, but there is this chronic element to it as well. How have you seen the stigma around HIV change over the course of your career? A lot, yes. I remember when we first had patients in with HIV, they would go in single rooms and the nurses wouldn't even go in the room. They'd sort of throw them it was usually a man, not always, but usually a man, and they would throw them a bottle and say, here's your bottle. And they didn't really want to go in. And they put food on the door and say, your food's ready, and the patient had to come and collect it. So yes, that has changed a great deal. There is still a lot of stigma about HIV, particularly in some communities. We've done a lot of work in Guatemala, and people just do not discuss HIV there. In Lagos, in Nigeria, patients may get diagnosed with HIV at one clinic, and then they go to another one for care because they don't want to tell anybody that they've got the infection. So there's still a lot of stigma attached to it. But of course, it is now, if you take your medicines, if you diagnose it before you're desperately ill and you take your medicine, actually, you can live for decades with HIV as long as you keep taking your medicine and you're carefully monitored. So I remember a young girl at age 4 that we diagnosed because her mother came in with HIV and died, and she'd obviously caught it transplacentally. And she was still absolutely fine at age 18, absolutely grand. You know, she'd grown and she was normal. So you know, but there are issues there about, you know, if you were a teenager with HIV taking HIV medicines, would you do a sleepover with friends? And they say, oh, what are those tablets you're taking? You know, oh, you got HIV? Ooh, you know. So there are some really interesting issues around the social side of HIV, which I think are pretty complicated.
Yeah, just to kind of follow up on that, do you think that the stigma around HIV has contributed to perhaps patients being unwilling to seek treatment or unwilling to present, and specifically with populations that already deal with a lot of prejudice in society? How do you think that has impacted their ability to get access to proper care? Yes,
I do. So, you know, if you were, I mean, there's lots of examples, but let me give you 2 or 3. If you were married, but you were actually bisexual, and you caught HIV with one of those other relationships, how are you going to feel about telling your marriage partner that you've got HIV? Ooh, you're not going to rush to make that diagnosis, are you? That's a really difficult area, right? Or you had an affair. You don't have to be bisexual. You just had an affair and you caught something, right? So I think that's one of the problem areas. Some people catch it, of course, with needles and drug abuse. So there's that group of people tend to be not very good at coming forward for healthcare, as you know. It's not a group that is healthcare seeking. So I think there are a lot of impediments to seeking care. And one of the ways of making it better is to have a completely confidential system where you can have a diagnosis made. And in the UK, a lot of the HIV diagnoses are made in genitourinary clinics, where there's a huge amount of privacy around medical. Even the medical notes are separated by law, so you cannot see somebody's STD infections. They just do not appear in your medical record. So you've been tested for syphilis or gonorrhea. You just don't see any of it. You can't see it. So I think there are some ways of trying to protect that confidentiality, which are systems-based ways, in addition to trying to get people to come forward. And then, of course, there's the prevention, getting people to wear condoms and, you know, and safe sex. We had, when I was a young doctor in the UK, we had the government ran an ad campaign, and there was an ad with a double coffin with a lad and a girl lying next to each other. It sort of grayed out, and the bottom, the writing said, "Bang bang, you're dead. AIDS." It was very hard hitting. You know, it was sort of like this. But it was trying to make this point: safe sex is important, and so on. So there's some of it's around awareness and so on, but it is a big deal. This, yes, your point is a good one, I think. Derm, yes, skin disease, yes. So as you go into medicine, I'm going to give you sort of generic, sort of a few comments about this, because we all have different memories, right? We're good at some things and not so good at others. Some of us have very good auditory memories, and we can remember the story and remember what they said. And that's a really important part of psychiatry, for example, mental health, to remember the detail of what somebody says. It's also important in primary care because you follow patients over long periods of time. we all have to do some listening, but in all of areas of medicine, but that's particularly important. In dermatology and radiology, it's all about what you see, right? It's on the x-rays, on the skin, and also in pathology, histopathology, it's about, so it's a visual memory, really good. Oh, I've seen that before. I know what that is. I recognize that. Boom, it's a visual memory thing. And some people are very good at processes. They remember how the hormones work and the sort of balance of up and down and all renal function and all those. They're very good at processes and the ebb and flow of things in the body and how they work. And some people have very good pattern recognition for sort of stories that fit particular things. And that's one of the things my brain's good at, is I recognize, they've been here, they've got this funny rash, they've got this fever, it's 3 months after they came back, that means it's this diagnosis. So it's a little bit like a detective thing, but it's putting bits of information together. So it's a pattern recognition of disease. But you're quite right that in infectious diseases, dermatology and skin rashes is quite a big deal. It's either a big deal on the skin or mouth, but it's also radiology. There's a lot of imaging which we use in infectious diseases as well. So it's a combination of that image thing. So one thing you might think about as you're going through, applying to med school and thinking about which topic area you might be interested in, do you want, how does your brain work and so on. I've got a colleague who loves drama. She just loves the drama. So anything exciting, she's all over it. She just loves it. She really should have been an emergency surgeon, I think. That's what she really, a trauma surgeon or something like that. Other people hate drama. Most dermatologists, the last thing they want is drama. They want a nice, steady life with everything organized and so on. So some people love the drama and some people love physical things. They like to do things. They want to use their hands. They want to put endoscopes down or bronchoscopy or, they want to do stuff and they don't want to sit there and just talk and listen and look at things. So we all have our different skills and so on. So have a think about that, where you might fit. You won't really know until you do it and nobody will know, but you'll have a sense of, that you're a very organized person and people ring you up and saying, please go and see this urgently ill patient. Oh God, I'm trying to get this done and I don't want to be disturbed. That the ER thing might not be for you, for example. So HIV medications advancing in Europe at the same rate. Yes, they are. So there's the HIV treatment cocktails that are available now are so much better than they were before and so carefully geared to the different patient groups. We haven't finished that story. There are still patients failing antiretrovirals. In Africa, it's around 11% fail. But a lot of that is patients not taking medicines. Sometimes it's because they acquire a resistant infection from somebody who hasn't been taking their medicines, but often it's because they're not taking it themselves. And so the counseling and advice to patients is a really critical part of good HIV care, as it is for a lot of medicine, but it's particularly important there.
So, Dr. Dennings, do you have any last advice for our members that are watching your live session today?
Any last advice, final advice, you mean? Yeah. I would say two things, I think. One of them is that medicine is, it is a vocation, it's not a job. You have to really want to do it and you want to have to dig in. And at times that can be really tough because you get very tired sometimes. And some of the emotional situations you end up in are really tough. And you just have to take some time out in your head, maybe physically, and take some exercise or something, which is important. That's one thing I would say. It's not, if you go into it because you can earn a bit of money or because you can do this specific thing, that's probably not the right career for you, I think. It is a vocation. The other thing I would say is that, as you can tell from, I think from my talk, that it requires lifelong learning. This is an area which continually is moving. I can't tell you how fast the COVID has gone in terms of learning in the last year. I gave a talk in June to some various Ukrainian doctors, and I tried to give the same talk 2 months later, and I had to change half of it. In 2 months, there was that much to change. It was astonishing, the speed of things. So it's not, you know, it's a lifelong journey in many ways, in sort of a sense of learning, but also the experiential part of it, of learning, not just sitting down in books and, you know, checking that article, but that experiential part of learning and growing and working with other people. And it's very much a team sport, medicine. You know, yes, you can be the greatest, you know, lung surgeon or cancer doctor in Atlanta or something, but it's a team sport as a general statement as well.
Thank you. I love that. And I do agree. So I believe we are ready for the wrap up of this session. Once again, thank you so much, Dr. Dennings, for bringing us such informative presentation. And I do think we all learned a lot from it. Considering this,
very welcome. Yeah, you're welcome.
Oh, I'm really sorry. What were you saying?
I just was saying you're welcome, that's all.
Don't worry. Well, considering this, we would like to encourage everyone to reflect on this session today. What brought you here today? What are 3 major takeaways that you got? And what do you want to learn more about? Let's let that sit in, think about it for a moment, reflect on it. We do want to acknowledge that this writing or reflection is not required. However, we encourage you to submit it to our website for publication for recognition of your hard work and to enhance future applications. If you want to learn more about pre-health shadowing and get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, social media promotion, and such. And we are also accepting team members if you want to take on a more active role in PHS to lead projects and initiatives to be up here with us. Once again, we are humbly asking that if you are financially able to donate, please consider sending a few dollars just via Venmo or PayPal, whichever works for you. It costs a lot to keep our program up and running and free to all of you. So if you're someone who can afford it, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, we simply ask you to spread the word about pre-health shadowing to reach as many students as possible. Now, for the part you have all been waiting for, earning your digital certificate for the virtual shadowing hours from this session today. Number 1, please go onto our website and find our professionals course pages. In this case, for example, Dr. Denham's page. Next, you can go to our quick 10-question multiple choice quiz based on the content from this session today. You will have 30 minutes per attempt to earn 70% or higher to get your certificate. We do know that sometimes technology can be difficult, and for this reason, we will be allowing up to 2 attempts to take the assessment. But if you run into any difficulties, please contact us. To ensure that our website does not crash from a high influx of students, we do recommend, please, waiting 30 minutes to an hour after the session to take the quiz, which will be open indefinitely. Once you have passed, you can click the Finish Course button at the bottom of the professionals page and download your certificate verifying your virtual assessment hours. If you missed a part of this session or want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessment for these as well. Be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming sessions and events. We are currently booked every weekday through June for virtual shadowing sessions, so we definitely hope to see you guys there. Once again, thank you for joining us today, and please stick around if you have any questions, and myself and other team members will be happy to answer them. This shadowing session is finally over, and we invite you all to log off. Have a wonderful day.